Welcome to our training to discuss collaborative problem solving in rural and small counties. We're excited to bring some learnings that we have heard across small and rural counties that they've begun implementing the CARE Act process in their counties, and also share some problem solving strategies that we thought could be useful for you today. Today, we're pleased to be joined by our presenter, Lisa Harrison. Lisa Harrison is a seasoned physician's associate with over 20 years of clinical experience, and she works on CARE Act, helping counties problem solve and serves as a liaison for some of those counties. So let's take a look at our agenda today. So the first section of our agenda, we'll be hearing some creative collaboration strategies in small and rural counties, sharing what we've heard across venues. And then the second portion of our presentation, we'll be hearing learnings from a few different counties and focus on what they've done. And this comes from a live presentation. And then Lisa and I will come back and share some things that stood out to us from that presentation. Let's take a look at our learning objectives today. Our goal is that by the end of this session, you'll have an increased ability to apply strategies to enhance care implementation in those rural areas, talking about a few things including remote participation options, addressing financial constraints, and fostering partnerships with key community stakeholders. Another learning objective is to develop approaches to expand workforce capacity, such as integrating peers and collaborating with partners, and then identify methods to increase mental health and care literacy, leveraging partnerships with local organizations, telehealth services, and community advocates. So with that introduction, I'll turn the time over to Lisa Harrison. Lisa?
Awesome. Thanks so much, Patricia. Appreciate being able to share this presentation with you all today. So in this section of the presentation on creative solutions in rural and small counties, we're going to be presenting a set of creative solutions for the rural and small counties that are implementing CARE. And this training is hopefully going to spark some ideas and creative solutions to common situations faced by rural and small counties. Okay, next slide. So implementing CARE in small and rural counties has proven to be quite a bit of a challenge in many cases for folks. The National Rural Health Association has identified challenges related to accessibility, availability of resources, affordability, and sometimes acceptability. In this training, we're going to be sharing some strategies discussed by rural and small counties in California for their CARE implementation. And this training is intended to provide ideas for effectively implementing CARE, but keep in mind that ultimately the behavioral health county staff and experts are the folks who can decide the extent to which these ideas could be effectively applied in their county based on their circumstances with the geography as well as their workforce. So in reviewing some of the strategies that rural counties could consider for CARE implementation, we can think about some approaches related to the following: increasing options for remote participation, expanding workforce capacity, addressing financial constraints, increasing mental health and care literacy, fostering partnerships, and developing a strong relationship with the court. So we're going to have more information on each of these in the upcoming slides. So when we think about increasing opportunities for remote participation, we can think about both the behavioral health and the court's processes in providing these services. So one of the things that we can think about is telehealth, which can encompass a broad range of services and tools to help reach and enhance patient engagement, healthcare delivery, and education for those folks that need in-person visits. So telehealth is a good opportunity to think about how you can pivot to making sure that some of these services are available. And we can also think about telehealth and teleparticipation, if you will, for court hearings and when transportation and mobility limitations impact the respondent's ability to participate. So not only does it allow the respondent more flexibility, but it can also expand the use of specialists in counties with limited provider choice, language diversity, and where there's just not enough workforce members to help support the needs for working with the respondents. So incorporating remote participation and encouraging this for behavioral health services and court processes, especially in these rural areas of many counties, can really enhance access to care. And some strategies that are suggested encompass both expanding remote services and flexibility. So for instance, providing, as I mentioned before, telehealth services for behavioral health assessments, even treatment. And also this can include video conferencing and phone consultations, and even looking at the technology that can help provide secure messaging to and from care teams, workforce, for the implementation of the CARE Act, and the respondents and any of their caregivers. You can also work with the court assigned to the care process to implement virtual court options for hearings related to behavioral health cases, and do have some counties that are working on engaging this opportunity right now for virtual court hearings. So it's good to hear that some of those opportunities are already being advanced. And also thinking about grants and other funding opportunities to support the development of remote services and the technology infrastructure. In helping to facilitate technology access, thinking about collaborating with schools, nonprofits, libraries, healthcare providers, housing providers, and anybody else that may be part of the care process to create a network of support for these remote services. Consider ways to provide devices, tablets, smartphones, any of those kinds of resources with preloaded technology, or even having folks that are engaged in the community to help folks learn how to use the technologies that may be available to them. Establishing community Wi-Fi hotspots is a really good opportunity, and especially doing that in public places such as libraries or community centers to enable remote participation. Please make sure that you do plan for privacy considerations when you're thinking about this opportunity, because again, working in these locations may not always have a private compliant section of their, something that could be HIPAA compliant, if you will, in different sections of their facility. So make sure that it is something to consider, private rooms and private areas where these conversations can be held without worry of others overhearing. Also, training respondents and partners on different technology. I just mentioned that. And you can offer workshops using technology for both service providers and respondents to build the confidence in using the technologies that can be involved in remote participation. And one of the things that is tagged on this slide is a link to a SAMHSA resource that summarizes a set of barriers to mental health substance use disorder treatment and services in rural communities, and this can help to present ways to use telehealth to overcome some of these barriers. So please don't hesitate to check out that link. So for this slide, when we think about expanding workforce capacity, we've heard from multiple cohort 1 and cohort 2 participant counties that workforce shortages are impacting care implementation. And this has been a significant conversation for many of the meetings that I've been part of. And this fact of workforce challenges is especially appropriate to talk about it for the rural areas. And again, we have a lot of workforce challenges and shortages in these areas compared to more rural and more urban areas, pardon me. Rural counties can consider incorporating strategies to address the workforce shortages, such as delegating responsibilities by assigning certain tasks to specialized staff where possible, such as administrative tasks, basic care management, and allowing highly trained professionals to focus on the more complex aspects of care. Simplifying program implementation by breaking down the program into manageable components and phases. And this can allow for gradual implementation and adaptation that can reduce some of the immediate burden on staff as they are balancing the roles and responsibilities for care implementation along with their other routine daily roles in their jobs. Also, thinking about collaborating with community organizations and universities, partnering with academic institutions for internships and field placement can be very helpful. And this can help you think about how you can develop a pipeline of trained professionals familiar with your agency's needs and services. And you can use this also to help work with local community organizations, nonprofits, and extend the reach of services and shared resources. You can incorporate peer specialists who have lived experience with mental health challenges, such as the ones that are involved in the CARE Act with regards to schizophrenia spectrum and psychotic disorders. And some folks who can have more of a background on this can offer unique insights, support, and their involvement can really help enhance engagement and understanding about the CARE Act processes and needs. Additional ways that you can facilitate workforce development and capacity are through mentorship programs, leadership development programs, on-the-job training, and other employee incentives that you may want to consider within your county structure. And these are excellent ways to also expand workforce capacity. Okay, so for the slide on peer supports, we want to consider exploring the use of additional peer supports in your county teams, because this can be a significant opportunity to help with workforce capacity. And there are different terms for the peer support role, because SAMHSA refers to this role as peer worker, while peer support specialist is also a common term specifically within peer organizations and county behavioral health agencies. But regardless, SAMHSA speaks to the broad range of the peer support role, which can include some of the following activities that may be applicable in your areas. Advocating for people in recovery, sharing resources and building skills, building community relationships, leading recovery groups, and mentoring and setting goals. Also, SAMHSA notes that peer support roles can extend to providing services and/or training, supervising other peer workers, in many cases, developing additional resources, administering programs or agencies, and educating the public and policymakers. And one of the examples that was brought forth about being a champion for the use of peers is in Butte County. And they've been using peers for a long time. And they've used them in their housing teams, crisis teams, outpatient services. And they've got strong peer community champions as well. And that's something where if you are thinking of using peer supports in your community for CARE Act implementation, think about making sure that you have earmarked some community peer champions that can help to facilitate and advocate for the opportunities in the community with regard to the CARE Act. And Butte County have reported that their peer staff connect with folks on a different level and can have conversations in a way that intentionally are less clinical and can really help get folks engaged and get folks in the door when it comes to working in some of the opportunities that we have talked about here. And this is definitely going to translate in Butte's care team, where they're going to be reaching a lot of these populations that we've been talking about that are in need today. And the hope with using the peer model in their county is to have as many peer workers and peer colleagues as part of that process as possible. Okay. So for the process of recruiting peers, we want to be creative in how you consider recruiting peers to your teams. So think about some of the following: using core competencies as guidance and inspiration for recruitment for both certified and non-certified peers. And the core competencies of peer support can offer some examples for you to include. For instance, in the job posting, determining the team structure that may help the peer supports thrive. And also, it can help you to identify interview questions when thinking of recruiting peers. There's also a growing number of individuals that have peer support specialist certification. And one of the things that is really nice about California is that the California Department of Healthcare Access and Information, HCAI for short, actually funds programs that can provide free Medi-Cal certified peer support specialist training and 6 months of job placement support. So think of these things as opportunities for ideas of how to recruit peers and get them involved in the process for the CARE Act for your county. And at the bottom of this slide, I apologize, thank you so much. At the bottom of this slide, for more information on peer supporters, there's a good link here for the supervision of peer supporters training. So please don't hesitate to take a look at that resource, as it may be very helpful for you and your team. Okay, so for thinking about how we can look at financial constraints, because again, this is an opportunity for rural and small counties to really think outside of the box, especially when there's a lack of funding for implementing some programs with severe mental illness and the challenges therein for getting these programs established and up and running. But there are different strategies that county behavioral health agencies can use to address financial constraints. So thinking about leveraging grants and external funding, seeking out federal, state, and private grants specifically aimed at mental health programs can be one opportunity to consider. And many organizations have actually opted to think about these opportunities for funding for different and innovative approaches and improvements in mental health care and how they can help to fund some of the needs for the CARE Act and the CARE Act implementation. So maximizing and BRAID funding sources. This is something that, again, there's more funding for housing and homelessness available throughout the state than ever before. And this includes state funding programs through CalAIM, Proposition 1, Behavioral Health Continuum Infrastructure Program, Behavioral Health Bridge Housing Program, and even more. So while this is generally really good news that there's more funding across the state for these opportunities, we want to think about how complex this can be. And it can be very complex. So thinking about when we talk about braiding funding, it refers to bridging together numerous funding sources for one program or goal, and while carefully making sure that we're complying with requirements for each one of those. And this can require thoughtful planning and new procedures to avoid double billing and making sure that we're ensuring one source to comply with funding requirements for each of these different programs. So we want to make sure that we are supplementing our funding, making sure that we're avoiding double billing, and that this funding is supplementing but not necessarily replacing another when we talk about the braided funding opportunities. But with the appropriate infrastructure and planning, pursuing and braiding these different funding sources can improve and expand counties' housing systems for sure. And this is something that we have seen both Cohort 1 has utilized these opportunities with braided funding, and a lot of our Cohort 2 counties are pursuing these opportunities as well. We also want to think about partnerships with nonprofits and universities and other organizations that may be able to provide some other funding resources and structure. We want to think about increasing our efficiency by sharing resources such as facilities and administrative support with other agencies or organizations to help reduce costs, streamlining processes, and implementing efficient and operational practices that can help reduce costs, and making sure that we're thinking about this in a way that we look at how we can better enhance and manage our data, streamline the administrative processes, and improve some of the workflow designs and workflow efficiencies that we can put in place. We will also want to use technology, making sure that technology can help us in automating tasks, reducing administrative overhead, and enhancing the service delivery, as I said, through some of these workflow considerations. Making sure, as we had just discussed, by including telehealth and other electronic health and digital record opportunities, EHRs, these opportunities can be particularly cost effective in helping us to manage our efficiency and increase those efficiencies as we implement the care process. And we want to make sure that we're engaging the community and getting folks involved, recruiting and training volunteers to provide administrative assistance and support services, and also with community-based solutions, involving the community in finding creative solutions and leveraging the local resources that you have. Community support can also be helpful in fundraising and other advocacy efforts. So as we move forward and think about increasing mental health and care literacy, we want to think about some of the challenges and opportunities that rural communities have in improving the individual mental health literacy. And that can be by building skills and helping residents to manage their own health and well-being. And counties can implement models that focus on improving communication techniques and strategies within healthcare systems, making it easier for individuals to navigate and access the services. This can include providing education to primary care providers, emergency departments and first responders, social service providers, and community-based organizations. So getting everybody in on this opportunity to educate around mental health literacy and educate around the CARE Act and what it is intended to do is going to be very important. So making sure that you're improving personal and community and organizational mental health literacy, as well as leveraging community resources to help maintain consistent messaging and information around the care processes. So increasing the literacy around care across the community really can also help to reduce stigma in the rural counties that may be present or prominent in some cases. And this can make it very easy to talk about the care process and helping to connect individuals with different services and supports. And we want to make sure that the community stakeholders, residents, families are aware of the CARE Act and what it is intended to address, making sure that we address any misconceptions, such as around eligibility or LPS conservatorship, and making sure that folks have access to materials and presentations for the CARE Act and what it means, and making sure that there are community partners and system partners like law enforcement, hospitals, and community-based organizations that are part of the mental health and care literacy process. Rural areas can also use a couple of other really unique opportunities and resources to help with this and improve mental health literacy. And these advocates can be community health workers and health extension agents. Community health workers we have seen in many, many settings to be a very important asset to programs as they can mirror the culture, language, and experience of community members. And rural CHW programs have shown promise in helping people to understand materials, learn how to manage chronic diseases, and help in understanding how to navigate the healthcare system. Another term that you may or may not have heard of are health extension agents, and these are health workers that have a variety of credentials who can also serve as educators and trusted sources of information within our communities. Health extension agents focus on a specific scope of health, such as depression, for instance, and they're experts in their field and can provide education and resources to help improve health literacy and link communities together for the process of CARE Act. So for our next slide, in talking about fostering partnerships, fostering partnerships with different stakeholder organizations can really improve coordination of care participant outcomes. County behavioral health can arrange partnerships to achieve coordination goals by sharing resources and data, making referrals, enhancing communication, and exchanging best practices. We've heard from some small counties that they've built upon previous relationships with stakeholders, and this has really helped to bring even more stakeholders to the table. So we think about the workflows that can be easier due to good working relationships with stakeholders, whether it's, the courts, jail, forensic teams, the sheriff's office, other first responders. And this can be a huge benefit in these counties that are smaller and have the smaller, geographic footprint, or even have larger geographic areas within larger counties that are very rural. So this can be an opportunity to really help build more good connections and relationships within the county by fostering these partnerships. And this slide illustrates some of the partnerships that can be included. And, think about how small and rural counties can benefit from having shared processes with neighboring or similar counties. And Butte County is an example here where their Superior Court has a partnership where they also support their neighboring Cohort 1 county, Glenn County. And their court has done a lot of infrastructure building and engagement with stakeholder groups. Another county or combined county that is doing much of the same with some of the neighboring counties and behavioral health supports is one with whom I'm working, and that's Sutter-Yuba County. They're doing a lot of partnering with other counties and thinking about resources and workforce shortages. Primary care providers. This is another great opportunity from a clinical standpoint to partner with local primary care clinics and facilitate integrated care models, which can help with allowing for coordinated treatment of physical and mental health issues. Agricultural organizations, think about partnering with local farms or agricultural cooperatives to create therapeutic or programs or job training opportunities. And this can also provide meaningful engagement and support for individuals with mental health challenges. Collaborating with institutions can lead to initiatives like mental health awareness programs, internships for students in psychology or mental health. And think about teaming up with organizations focused on housing, employment, social services, and helping to create comprehensive support systems to address the many different aspects of individuals with severe mental illness and how these folks can get connected via schools and resources and universities. Faith-based organizations, you can think about, again, partnering with local churches and religious groups to help provide community support networks and outreach programs and holistic approaches to mental health. Nonprofits, social services, think about teaming up with organizations focused on housing, employment, social services to create comprehensive support systems that can address the multifaceted needs of folks in this respect as well, and folks who have limited access to providers. Veterans organizations, collaborating with local veteran support groups can help address the unique mental health needs of veterans, provide targeted resources and services for veterans in our communities. Utilizing family members can be absolutely very helpful in figuring out the best way to engage individuals, identifying treatment that may or may not have worked in the past, and providing helpful information within their communities. County behavioral health has different constraints, of course, on what can be shared with and without consent when it comes to family members and other caregivers. But that, again, does not preclude folks from being able to seek information that could be helpful in informing treatment and engagement. And one of the other things that has been a very big topic that we have come to hear a lot about in many rural and small counties is how to improve access and partnerships for transportation. Rural counties and communities are implementing programs to increase access to transportation. And these are some things that can be, modeled in rural counties that involve strategic planning, community buy-in, and commitment from a wide variety of partners and community stakeholders. And the most appropriate mix of program models could potentially depend upon the rural community's needs, the target population, and available funding, as well as the community needs and community characteristics. So in developing strong collaborations within the communities, we want to think about those partnerships and collaborations with the court as extremely important. You want to consider leveraging existing partnerships with courts from other programs. So consider, AOT, LPS, any of those other kinds of programs, and consider meeting on a routine basis and staying action-oriented by connecting through implementation guidelines, action steps with agencies, and working towards getting the right steps in place. And this is where existing partnerships with courts can be very helpful. Making sure that you've got a liaison between the courts and county behavioral health. And so this is somebody that really needs to help understand the needs and strengths of both groups, because again, when it comes to the courts and county behavioral health often have similar goals. I mean, sometimes they may be different, but sometimes they are very similar goals in helping folks. And they sometimes can speak in different terms between behavioral health and the courts. So identifying a liaison that understands both and can help bridge that potential communication gap in understanding what each other is doing is very important and very helpful. And this can help to really translate and build that collaborative relationship between these two factions. Making sure that courts are aligned on eligibility requirements and the nuances of different diagnoses, and having open discussions on the CARE Act eligibility requirements to ensure that both behavioral health and courts are aligned with their interpretation and are on the same page can help to explain to each other and petitioners the determination on eligibility. So when I think about how, small counties may be able to prioritize funding to potentially, in an example, hire a psychologist who can help explain the nuances of diagnoses. And this is something that we've seen in a couple of different areas. And I know of another county that is in the process of hiring some folks right now to fill this kind of a gap. And ones who have hired to help fill this gap and create a liaison role between courts and behavioral health have reported that this was a very, very valuable step. You want to make sure that you're coordinating training between available services and with self-help centers. Self-help centers are run by the Judicial Council of California, and they can offer legal guidance and support for individuals that don't have representation. So county behavioral health and the local self-help center can coordinate available services beyond care and can help identify protocols and referrals for services regardless of care eligibility. County behavioral health can help provide training and education on serious mental disorders, and self-help centers are available for those seeking help and education on what services are available. So coordinating the training with self-help centers can also be a very, very rich resource. Consider developing a memorandum of understanding, an MOU, with the courts to address concerns around information sharing. This is something that some counties may want to consider, as they want to be conservative with the information that's being shared. However, there is a level of accountability for county behavioral health to release the right information to get the work done. And an example of this is in Kern County, who has worked with their county council, who oversees Health Insurance Portability and Accountability Act, the HIPAA. And this is something that the MOU has helped with information sharing that has been put into practice as this MOU, so there aren't concerns around surrounding that portion of care. This next slide highlights some of the many resources that are available that can address the unique needs and topics for rural counties and rural areas. Some of these links provide access to a variety of evidence-based toolkits which offer more information on the topics discussed today, such as integrating community health workers, improving health literacy, and even developing a telehealth program. So make sure that you check out these resources. I won't go through each one, but there are some very valuable resources here. And those evidence-based toolkits and things that are state-specific, I think you will find very, very helpful. So for the next slide, I want you to think about ideas in action. This is a question to think about. Which local partners could you potentially invite to participate in a cross-agency work group to improve coordination and collaboration? These are some things that we have talked about with a variety of different counties, both Cohort 1 and our Cohort 2 partners that are getting ready to implement. And as I had mentioned in some of the previous slides, we've seen folks that are inviting transportation agencies, housing agencies, private partners to engage in these conversations in order to help improve coordination and collaboration around the CARE Act and the needs as we get closer to Cohort 2. So think about it for yourself in your county and what kinds of things you might be able to do to get some of these ideas in action. And with that, I will actually turn it over now to my colleague, Patricia, to continue with some information and introduce some of the folks that are part of our county spotlight. Patricia, over to you.
Thank you, Lisa. So many of the strategies that Lisa shared that could be implemented at the county level came from not only the resources that she shared, but what we've been hearing from small and rural counties who have already implemented CARE or who are in the process of doing so. And so now we want to turn to representatives from those counties themselves to hear about what they're thinking about, things they've tried, and what's been successful in their county. So let's meet some of those panelists before we turn to that live discussion. So we have Isaac Matei, who is the clinical forensic supervisor for Sutter Yuba Behavioral Health, and he's responsible for the implementation of their CARE work and then also supervising the clinical work at Sutter County Probation. We also have Tammy Mariscal and Brock Kolpe from Tuolumne, and Tammy is the behavioral health director and has been there for 16 years across a variety of roles, and Brock is the deputy director for Tuolumne County Behavioral Health and a rural behavioral health clinic. Joe Hallett and Kristen Doyle are from Glenn County and have been there for a number of years working across different roles. Joe has done some work at the emergency homeless shelter and also has done some social work as well in Glenn County. And Kristen Doyle is the program manager of adult services, and she's been with the county for 17 years. So we'll go ahead and turn to that conversation now.
We'll start with our county spotlight to share some of the innovative solutions, challenges, and lessons learned from folks who have either already implemented CARE Act or for those who are beginning that process and gearing up for implementation in December. So we'll start by giving the floor to Isaac to spotlight Sutter Yuba. And Isaac, feel free to take it away. Give us a little background on yourself and what's going on for Sutter Yuba.
Thank you, Lisa. Hi, everybody. My name is Isaac Matei, and I'm the clinical forensic supervisor with Sutter Yuba Behavioral Health. I'm responsible for the care court and also the probation department and also the forensic department that we have. And we are in a pre-implementation phase, and what we did in our pre-implementation phase is we hired a consultant who facilitate meetings between behavioral health and courts and all the other stakeholders. We have for each county monthly meetings for the as a work group, and then this month we started with two separate subgroups, one for court, the legal aspect, and one for behavioral health and housing. And in these groups, we address the two tracks. And the goal is in September to do some simulating exercise, a kind of mock drill for taking from the referral to the care agreement, care plan, graduation, a client taking it from beginning to toward the end and how that will work. What we have been really blessed is that in the last 2 months, one of the county councils that transitioned from Glenn County that already implemented care, the care court, and so he's huge, a valuable help and connection between behavioral health, courts. So he's really very experienced in what works and what needs to be improved in communication. Also in our communication, I think one of the most valuable thing that I experienced since our first rural affinity group that we had, I started meeting with our liaison from HMA, and it happens to be Lisa. So Lisa, you've been a huge help in a communication, connecting with specialists in data, connecting me with people that have experience and can come alongside. So I think I would encourage if you haven't connected with your liaison, that's a huge help for us. So that's a little bit about us, communication, and yeah, we still try to buy in a little bit of to be efficient with the court aspect, but our county council, like I said, it's a huge help. So thank you.
Awesome. Thanks so much, Isaac. Really appreciate it. And now we'll turn it over to our friends from Tuolumne County for a spotlight on their programs and how things have been going.
Thank you, Lisa. My name is Tammy Mariscal. I'm the Behavioral Health Director here in Tuolumne County. I'm excited to be here. Tuolumne County implemented Care Court in October 1st of 2023. We had barriers, challenges, and strategies, lessons learned, very similar to all of the other Cohort 1 counties. Our specific challenges really were looking at our staffing structure and the lack of capacity that we were facing, and really needed to take a look at what kind of population could possibly result from petitions going forward in October. Funding for our county council was a concern, knowing that the Care Court implementation funding was specific to stand-up programs, but wasn't necessarily in place to cover ongoing county council expenses as it related to hearings. Timelines of the CARE Act were a concern. Very short timelines related to petitions, serving of the respondents, and the various hearings that would follow those petitions. What we learned was that the court is very forgiving and compassionate towards the population that we are trying to care for. So we've actually experienced some relief from those timelines, as the court has authority to provide continuations and lengthening those timelines that are within the bill. So that was exciting. We really wanted to make sure that our staffing had a forensic specialty. So we really looked for bringing up a program specialist that could really understand and engage in the CARE Act and understand the spirit of not just the CARE Act law, but also the voluntary aspect of outpatient mental health, as we all have experienced in the past. Your diagnostics are going to be very important. I encourage you to look at what that might look like when you are having to articulate diagnoses through the court system. There's a lot of historical data out there on these respondents that you may have to level set and possibly test out. So Tuolumne County took diagnostics quite seriously, understanding that we may have conflicting diagnoses, and we've installed or hired a psychologist, so we're able to do testing. I think that's really important. Your partnering for your M-County, I think, is huge. Tuolumne County was fortunate. We had our county administrator who was very interested in care court and supportive of the process. Your health and human services director, we had she on our team as well. The courts came to the table. We had our public defender, our county council. We also met weekly beginning in July, actually at 3 different forums. We had a larger county system meeting where we had all the partners at the table, and then we would titrate down to those that were actually developing the program, so we could have a little bit more detailed conversation without pulling down a lot of our leadership's time. I urge you to look at the unknowns in your county as far as data, so you can scale properly. I think that Tuolumne County, although we saw this as a massive lift, what we realized was it's very possible that we were not going to have the flood of petitions that we all anticipated initially, and it actually worked out in that way. Petitions came in very methodically, I guess, for a lack of a better word, and in a flow that was actually very manageable. And yeah, I think that's about it. I want to leave a little bit of time for Brock if you wanted to share anything. Thank you, everybody.
And just kind of like what Tammy was saying, is that extensive planning process that we did was really invaluable because our partners were also learning what care court was and what our approach was, what the diagnostics of schizophrenia and other psychotic disorders might mean, and just that everyday processes. How do we communicate information? How is the court getting the petitions to us and vice versa? And so that the planning process was really important, that we have that, get all those partners involved, the Superior Court, and even sometimes there's people that might occasionally attend, like the CAO, the Superior Court, or people who are more involved, such as maybe the actual program manager at the Superior Court. And so this kind of building, we'd already had, like many counties, we have our other legal processes from our substance abuse programs or our mental health diversion, but this is putting us in a new role in terms of we were now being assigned as the petitioner and not just like a consultant coming in and giving our opinion on something or our progress report on attendance. We were the petitioner having to gather a lot of information for the court in a very short timeline. And oftentimes those records aren't available. So we did have to ask for maybe a 30-day extension to gather the medical records to find out what was going on with the person. Oftentimes different people in the community or family members, the petitioners would claim someone had schizophrenia, but they didn't have schizophrenia. So trying to show that court, because the court wants to see evidence of that. So trying to do our assessments in a timely manner, reach out to the person, meet that 14-day timeline, and then get the medical records that support that. Because the judge in our county would want to know, well, they had an assessment at a psych hospital 10 years ago. I want to know what's the diagnosis from that? And so the judge was really, they're wanting to see records, they're wanting to see proof, so to speak, of why, or an answer to that. So if the family says, well, they were diagnosed at Adventist Health Vallejo Hospital 10 years ago with schizophrenia, why are you saying they don't have schizophrenia now? Or why do you say they do have schizophrenia now? So really trying to help the court understand that, and understand that sometimes you might have a snapshot of a diagnosis based on one encounter, and that may not be the more permanent diagnosis, or that the fact that diagnoses are fluid, that diagnoses may change depending on the symptom profile. So, but really the biggest thing I think Tammy also alluded to was that getting the right staff in place. So having the forensic program specialist, the psychologist to help us with the assessments, and then the case management staff who are experienced with homeless persons, working with homeless persons, to really be able to engage them and go out there and do the direct work and get them and try to get those persons to court. Because you have homeless people who do not trust authority and do not want to be part of this process, and you're trying to do an engagement process and convince them to participate and help address their homelessness. So that's all I have.
Awesome. Great, Tammy, Brock, thank you so much. That was a lot of great information about your experiences as a cohort 1 implementer. Okay, so for the last county spotlight, before we get to the rest of our time today, we're going to, I'll turn it over to Glenn County, to Kristen and Joe.
Good morning, everyone. I'm Joe Hallett, Behavioral Health Director in Glenn County. And I have Kristen, if you want to introduce yourself too.
Hi, everybody. I'm Kristen Doyle, Program Manager of Adult Services here at Glenn County.
So yeah, I guess just probably similar to a lot of small counties, what I pointed out in our overview is that just the ton of collaboration we did to implement this from day one. We got everybody we could think of that might touch this program in some way together bi-weekly as we were planning, especially because, you know, being a pilot county and having no clue what this would look like at all or anything to borrow from at that point. And so luckily we had a really supportive team that representation from every single aspect of the program got together. And then, you know, as we're almost a year in October, it'll be a year. And we've realized the need for the program wasn't as great as we had projected when we started. So that was one of the lessons learned over the years. And you know, and I think being a small county, you'll probably have the same experience too, that you tend to, you know, often who's in your county and who might, you know, who's already engaged in services or not quite. And so when we have like community partners or those kinds of things suggest someone for care, it's like, oh yeah, that person's been adequately served or whatever the case might be. And not that we don't get, you know, we're on the I-5 corridor and we get some people we don't know in the county occasionally, but by and large, we were kind of looking at crisis and stuff, and the way we generated our numbers, we were trying to overestimate so that we wouldn't be, you know, caught underfunded and moving forward. But we haven't had a significant participation in the program yet. And then just some of our challenges. So like Isaac mentioned, we've had some turnover in our key staff, one being our county counsel, who was a great partner in it. We have a different public defender from when we started. We have, who else, Kristen? There was quite a few.
Just some of our staff. And so I think it's important if you try to implement with who's going to be in the program and the people who are going to be there, it's hard to retrain people. And that's where we're at now. We have partners who have changed or left, changed roles, et cetera, and people on our team as well. And it's really hard to retrain and go over this with a lot of new people. So if you can know who's going to do this, start with them and continue with them.
Yeah, changing our court CEO, changing the supervisor of the program.
Yes.
We're kind of in a mode of reteaching everybody this
Starting over.
Very complex program that it is. But one of the strategies we had for that is just we restarted. we thought because we had met bi-weekly for a year to get this thing off the ground, and so we thought, all right, it's ready, we're launched, let's cut back on the meetings for now. And then we realized there was little things, issues that would arise, and so we said, okay, let's at least meet quarterly and talk through these things, and then also now have some separate educational meetings with some of the partners that are brand new to it also. Like a good example, we all throughout our judges have been great partners, but then our very first petition, they're like, no, this doesn't, this isn't sufficient. I forget how they put it to us, but it wasn't sufficient for them to try to rule on, even if it met prima facie. So we had to go back. It's like, wait a minute, we talked through this. So, things like that come up along the way, and we sort through it. So already a question, how many petition referrals are you seeing? How many have we done total now, Kristen?
We were able, I mean, I think the things people don't always talk about successfully, like Joe mentioned, though, we had some referrals who actually were already engaged or that were doing other services or didn't meet criteria. So we've had one that went partway through the program, and we have 2 or 3, I want to say off the top of my head right now, that are going to be entered within like the next, probably this week, maybe next week. And actually an interesting thing in our county is we've not gotten outside referrals. So it's really been behavioral health initiating. But we did ask community to funnel to us because there is a lot of information that's required on the petitions that a lot of individuals don't have. So even if it's a family member or loved one or somebody involved in the care or around that person, they're not going to have documents of their mental health and diagnoses and all the things that you need. So if the person's funneled to us, we can know if they're involved in our services or not, if this is the right place to look at care act for them, or if there's a different program or other services, and to see if they meet criteria. Diagnosis is what's mentioned by Tammy. And all those things. And so sometimes it's not care and it's other programs, and we're the one providing the service or going to do care. So it really helps to funnel that to us in a small county. That may not make sense in other places, but for us, it just really helps streamline the process.
Yeah, it's hard with the requirements for an affidavit or the proof of intensive treatment. It's hard for other partners in our community to think about submitting a petition and how complicated it is. We don't have a huge network of other behavioral health providers outside the county that are waiting to recommend people for care or think they might have that diagnosis or those kinds of things too. So that's actually a segue into our next point is, the low petitions, but we developed just kind of a basic referral process so we can get some basic info ourselves and just do the petition if we think it's warranted or somebody we don't know. And so that's been one strategy we had there.
Joe,
there
was a question that came up in chat that I thought we could address also really quick, is the in-person legal notice. So our discussions initially was asking an not in uniform sheriff's officer to provide that, sheriff's deputy to provide the notice. We did not want somebody in uniform providing that. And that was agreed upon. However, when we came time to serve, they weren't available. It wasn't something they could immediately do at that point. And so we pivoted to be timely to have our, I'm forgetting the name of them, Joe. They're like our fraud unit.
Special investigations unit, the welfare fraud investigators that were closed.
So they're plain clothes, but officers still. And so they've agreed to take that on as not only the one time, but as an ongoing. So we pivoted to do that, knowing that we don't have a ton of them. That's a small unit, but they're agreeable. And it was sort of a middle ground that we could all agree upon. So that's what we're doing in our county. But I know somebody asked how are each of the counties providing that. So we can speak to that. Sorry, Joe, you were talking.
Oh, no, that's fine. And then I saw someone had mentioned population in the chat too. Ours is 28,000 in Glen, just to put that in perspective too. And then, of course, we'll probably get into more of this, but just the lack of housing infrastructure in a small county. I mean, Glen, we faced issues of, even when we've had projects like No Place Like Home, it fell flat. Just we get kind of landlocked, and then trying to get an agreed upon place to build. Like, when the only suitable sites we had found when we did go for No Place Like Home were out in the middle of nowhere with no infrastructure to them or access to services. And so we have a lot of farmland around, and then national forests and things like that. So we tend to get landlocked into the little cities, and then expanding is always a challenge, but it's definitely something that we look to resolve as strategies. We wrote infrastructure into our most recent bridge housing round three, which was funded, luckily. So that'll give us some more options. We have some regional providers, some in neighboring counties, and then one trying to start up locally that's not licensed yet, that we work with on how do we make this a genuine behavioral health type of residential program. And then we have an existing housing program that we partner with Habitat for Humanity. But it's not specific to behavioral health. It has a lot of our people, and we provide services on site. And so they're looking to expand. So as they do, we're trying to get in there and expand along with them as best we can. So our lessons learned are, if at all possible, have the people who plan this out with you be who's going to operate the program ongoing. That's been a challenge for us more recently, but if you can even get some of your staff involved in the program to the table sooner than later, and to know their role and really understand the essence of it. It's like I said, I mean, we've been doing this a year, and I still have to look, okay, what hearing is this next? And it's so complicated, the process. So staying up on that is a key. And then keeping those internal team meetings alive, like I said, working through issues. And then we opted to even do a pilot case, as as we were a soft launch per se, and just to try to get it down with the core room. Even if you're not ready for a full launch, to just try to get used to the court process and those kinds of things. And then we're realizing more now, just we had done quite a bit of outreach to the public at first, and we were on the news, and we go to the city councils and Rotary Club, and all these community events and table, and try to get the word out. Put a link on our home county homepage website and all kinds of stuff. But we're realizing that just needs to be continuous. There's still misinformation out there and lack of awareness, and HMA was great in developing a communications toolkit, and we're looking to that to use social media more often and get some posts out there. And like, I know probably not a ton of people always come to our county website, and probably find more folks mention Glenn County in the rants and raves page or something on social media. So getting the word out there is what we're finding to be more helpful.
Fantastic. Really appreciate that. Thank you, Joe and Kristen and Brock, Tammy, Isaac. Very valuable information, getting a spotlight on what's happening in your counties thus far. So we're going to take this now to the next section, where we're going to have some panel discussions around a couple of different topics around communication, housing, and staffing. And again, we've touched on some of those kinds of things as part of the county spotlight and introduction. But if we want to dig a little deeper on some specific questions and things like that, we'll have the opportunity to do so. And don't forget that we do have the Q&A session at the end, where we can start to entertain, other aspects of these questions, deeper dives, or other questions that may come up in general that, if they're not related to these topics, that's fine. We're here to answer and do as much as we can. All right. So we'll move forward and getting started with our discussion topic around communication. And the CARE Act implementation requires, I think, a lot of internal planning and planning with community stakeholders and other partners. And that foundation of communication is key. So for this particular panel discussion topic, let's talk about some of these questions that we have here about, what's been successful, what have you learned, and we'll go from there. So I wanted to spotlight Isaac first, because Isaac, you're in a really unique situation in the fact that you have two counties that are, intertwined with this whole process. You've got two courts, and I would like for you to tell us a little bit more about what you have learned thus far about communication between the courts, behavioral health. What have you found to be successful? What are some other things that you're looking to do as you continue towards implementation?
Yes, Lisa, thank you. What we did, the consultant that we hired was really helpful in facilitating meetings between behavioral health court, and on our regular meeting, monthly meeting for each county, they are either court CEO or part of the county council that are represented. So it's they are involved in, and we try to make as much a collaborative process as possible. So they are involved in discussions, and sometimes they are not able to do it in person, and we do it via Teams. But that's really helpful. And like I said before, having the county council from Glen, that was really a blessing in connecting. He knows. He used to be in our counties here years back, and now that he returned, he knows the public defenders, the judges, and he is such a good liaison between the two counties, and we are so fortunate to have him as part of the team with his old knowledge and from already implementing with Glenn County. So thank you, Christine and Joe, for that. And sure, it's also sometimes not easy because from the court aspect is, it's another thing that to do, and we already have behavioral court running. We already have some other aspects, and what's this different? How can you, if it's a civil court process, how would you get a clients involved? So that's a little bit of, we need to boost up a little bit and of the buy-in from the court and everybody else. But I think the two aspects were crucial: the consultant and the county council that we have. So
appreciate that. Awesome. So in thinking about the communication for Tuolumne and Glen, so Tammy, Brock, Joe, Kristen, tell us a little bit about what you've done to communicate with the planning partners after implementation.
Well, like we said, NARA's keeping a regular planning meeting, no less than quarterly. And I think the double-edged sword, the blessing and the curse of a small county is all the same people are doing the same thing. So in communicating, it's like, oh yeah, I see the judges at the drug court meeting and at the behavioral treatment court meeting and at 10 other meetings. So it's, you get the word out. It's like, oh yeah, we need to talk about care court too. So that's been helpful for us also.
Nice. Keeping that on the list at all times.
Yeah,
Fantastic.
I'm sorry, Lisa.
No, please.
Okay. I'd say in Tuolumne, we really ramped down as far as our planning meetings once we went live. And correct me if I'm wrong, Brock, I think it took us about maybe 6-8 months into the program where we realized we needed to get back to our planning team. So, we kind of had like, whew, we're done. And then really, we started to go a little bit sideways. So I'd say avoid stopping your meetings and just stay consistent. And quarterly is probably a little bit too long for a program just in their first year. So that would be our kind of thing. I think we would have avoided some speed bumps if we had stayed with the monthly meetings.
And I think most of post implementation was on an individual department level. So, okay, we're going to consult with county council on this problem, or we need to talk to the clerk's office. They aren't getting the petition to us in the right way, or how do we do electronic notification between us? And so just them learning how to work with us as an entity. And we're all in the same groups, diversion or drug court or whatever. But then sometimes in our county, we have about 4 judges or so. So the one judge was assigned to care court, but the other judges had less frequent contact, but it still came up. and then trying to educate them because they may not be as familiar with the process as the primary judge assigned to care court. So that was kind of a learning thing. And just those little practical things, like between the clerk's office and our or someone misfiles the paperwork and doesn't get it to the judge in the correct box. And so trying to track that down because we're trying to hit those timelines. And one thing I did was pleasantly surprised with some of the, with the new technology and the telehealth that the courts be doing now, that was very valuable because the judge would even allow us, we didn't have to do it often, but to do some kind of remote televideo with the client out in the field to the court. But it was all those little practical things as the court begins to learn how to work with our homeless people who may say they're going to show up to court, but won't. So.
Yeah. Appreciate that, Brock, and everybody. Thank you. Yeah, so for the folks who've already implemented, so for Glenn and Tuolumne, we understand that obviously, and as we're hearing more about this, that communication with the community stakeholders is one of the most important parts of the care implementation. But we understand that not all counties, especially the small and rural ones that are part of our forum today, have those real robust communication teams. So tell us a little bit more in detail about what you found to be most helpful when it comes to the communication, especially if there are no robust communication teams. What staffing have you used? And again, understanding some of the things we've heard before, and we'll talk a little bit more about later for staffing, but with staff turnover, and a little bit, tell us a little bit more about the communication channels that you've used, the websites, your social media, any of the community centers, those kinds of things. Help us to know a little bit more about specifically how you've engaged those resources to help with the communication.
So for Glenn, it's again another hat we often wear. Kristen and I do a lot of it. But one thing we did was hire a specific analyst just for care, and not only for the incredible data requirements, but she also she can help with the social media posting. She makes flyers for us, does website postings, and kind of manages that piece of it and the complicated court calendars and all aspects of it. So that's been really helpful for us too.
Nice. Everybody kind of pitching in to help with any of those tasks that's needed. Brock and Tammy, anything for you guys specifically with your strategy for those areas for the communication?
We hit all the normal forums, I believe. We used our Facebook, we used our website, we used partners' websites. We also did a upfront concerted effort to bring particular petitioners to forums. So we created a presentation for the first responders. We created a forum for families to join us through NAMI. So really wanted to customize, if you will, some of the presentations based on our audience, understanding how they view their roles. So I think that might have been unique. We also took advantage of the countless community forums that exist in Tuolumne. We met with the League of Women Voters. We met with, like I said, NAMI. We did presentations at our enrichment center, which is where our mental health client drop-in center. That was a really unique experience. Who I'm not sure who really thought, well, gosh, the clients might want to be educated in this. And so that was something I learned. It was an accidental presentation. I don't want to allude that we planned that so brilliantly, but what we did recognize was there was a heightenedness within the population that CARE Act was focused on. And it was causing undue stress for clients that, for all intents and purposes, were somehow engaged with our care. Not CARE Act, meaning our services. So I really, I witnessed a relief on our core mental health crew that were really worried about care court. So I encourage you, make sure you get out to the community that you serve. Yeah, we did radio spots. I think Brock and I did quite a few radio spots. Yeah, just really tried to get it out there. Oh, and I think also it's important. BH was not the only team that was doing communications, because we had county council being called to do presentations. We had public defender being called. We had the courts doing their own education. So we all shared the same slides. I think that's the one thing. It was really important that we were giving the same message, even though we might say it a little bit different, but that we were all on the same page. So sharing your media material, I think, would be really important, because you're going to avoid those social media posts. As Joe mentioned, we don't want to be on Yelp and chase them, we get that too. And so we want to avoid the social media, he said, she said, and not confuse our community. So that would be my 2 cents. Thank you.
Awesome. Thank you. There were some really good examples of, what you've done and how folks can, creatively think of how to approach some of the communication challenges that are part of smaller counties that may have resources that need, that are spread thin. So appreciate that. So thinking about the other things, that we have access to, the communications toolkit. One of the things Patricia just posted in the chat, the link to the communications toolkit, if you all haven't seen it yet, and also what it contains, Word documents, PowerPoints, flyers, talking points, things to help get you started with thinking about how you can utilize those resources. And also, if you wanted to see what others have done with their websites in helping with any communications, again, Patricia has put that link in there. So I'm going to open it up to our panelists to say, if you've used the communications toolkit, how have you used it? And especially for, I guess for Isaac, if you haven't yet used it as part of your implementation, what are some of the things that you think you might be able to do with that toolkit? So again, for folks either who have or have not used, tell us about what you think about the communications toolkit and how it can be useful, or how it has been useful for you. Just open that up to everybody. So if anybody wants to jump in, feel free.
Lisa, I think Glenn started ours before. There was a lot of particular things there. So
Okay.
We used messaging and photographs from the CARE Act so that we had similar pictures and verbiage from there. So we sort of just cut and paste and drug in to make our brochure, but using the same materials and same verbiage.
Okay.
So that's what we did, I think, before the toolkit was out, but we have utilized some of those pieces. I think the other thing we really tried to do was make the brochure easy for clients to read. So this is for people in the community who always have questions and don't always understand mental health terms and what we do and the differences, but also making sure that somebody who could read it, it was very clear language. And so we took a look at that and tried to change that up while maximizing a trifold and put in as much information also as you can.
Awesome. Great. Thank you, Kristen. So, I just took a look at the time. So in the interest of moving things forward, again, we'll put in another plug for the comms toolkit. Please take a look, see how that can apply to your county and your needs. And again, don't hesitate to reach out to your HMA liaison if you need any additional help with that or with the comms toolkit. So moving forward to our next topic, to stay on track, we're going to talk a little bit about housing. So we'll shift this discussion and talk about how, the eligible individuals who are unhoused, how we're going to utilize existing housing resources for the CARE Act participants. Because again, the focus of the work in the CARE Act and the statute is also on securing, stable housing for the respondents. So for folks who are getting ready to implement, we want to talk about how you're thinking of your housing and residential opportunities and launching new programs or expanding existing opportunities for folks. And we know that the respondents who have the diagnosis, who have SMI and are eligible for CARE Act, we know that the housing programs that are in place may not, necessarily be equipped or intended for folks who have these additional needs. So we want to talk about what strategies and supports you guys have in place or are thinking of putting in place to support the CARE Act respondents and their particular needs. So we'll start, I'm going to call on Joe and Tammy. We'll start with Joe from Glenn first to talk about what have you leveraged in your existing housing programs and facilities for CARE Act participants. Tell us a little bit about what's worked, what hasn't worked, and we'll start with that, and then we'll pose the same question to Brock and Tammy after you respond. Joe.
Okay. Yeah, so I think I got into a little of it in our spotlight, but so what's worked well for us is our partnership with Habitat for Humanity. It's called Purpose Place. It's a 33 unit apartment complex, low income, low barrier. But again, it's not specific to behavioral health, but we have a significant presence there. And working to partner with them as they look to expand that property and kind of align it with our bridge housing funds and see if we can do some behavioral health focused housing. And one thing we've really been trying to push is to do a master lease, which is where we could rent or lease a room or a bed as behavioral health and then move people in and out as needed with this kind of programming into more long-term solutions and not have to go through their main type of housing process. It's more designed to be a permanent kind of housing situation for people. So that's been helpful. And like I said, we have somebody looking to be a residential provider that isn't licensed yet, but interested. And so working with them on, best practices and how to get licensed and being a consult there. And again, that one also isn't specific to behavioral health, but something that we can try to guide that way. And then another thing we're wanting to do, we've talked to some like board and care providers that are outside the county and saying, look, if we get some infrastructure funds and buy a house, would you operate a board and care out of there? And that's been, people have been willing to look at that. And then even regionally, some of the larger residential kind of providers are saying, if we can get a certain number of beds there and you get other counties to agree, we'll pay for the costs of developing something in your region. And so so there's all kinds of ideas and things that we're chasing down. I guess just another question, what hasn't worked? It's just having nothing today. Like basically right now, Purpose Place is full. And so we've got motels or out of county board and care, basically our two options, no emergency shelter or anything like that. So these are longer term solutions, but they're needed solutions in the long run regardless, I think.
I would just add that we're finding our individuals referred are needing a higher level of care than maybe being able to stay in a motel room. They might need 24/7 oversight. There might be safety issues with cooking or being able to care for themselves or be safe like overnight. So while those might be available for short term or something like the weekend, it's not a good long-term option for the person to have stable, secure housing. And we really don't have other options in the county. So then the options we do have are out of county, which makes it really hard to serve the individual. So I would say also having an eye towards something where there's oversight, a manager, the ability to have more of that 24/7 wraparound is probably what you're going to encounter more, and how to plan for that.
Okay, fantastic. All right, so again, we'll keep things moving because again, there's so much great information. We all want to cover it and keep on going, but I want to make sure that I do keep on schedule with our time. One of the other things that I wanted to make sure that Isaac has an opportunity to share is what they're doing as part of their preparation for housing, getting ready to implement CARE Act. Isaac, if you want to share briefly a little bit about what you're doing for your planning and your current housing and transition to help meet the needs of the SMI population.
Yeah, we currently have an emergency shelter in each county for the transient population. And especially in Sutter County, we have it kind of in a neighboring, so it's almost the same location with our agency, with Sariba Behavioral Health, where we have case management, we have behavioral health staff serve and assist the housing population. So that's helpful. Also, we use once the homeless population is showing interest in changing from chronic homelessness, we partnered with business with some business in a community, and there are 2 apartment complex that was built in each county to help our transient population. And once they move in the apartment, they are helped by the staff, either with getting their Social Security, getting some financial assistance, and they contribute to their monthly rent. And so we try to stabilize and bring them in a functioning state. So then we also have board and care through our full service partnership, where we have staff and our clients are brought for our wellness groups and all kind of activity that we have here. So we don't have specific housing for the care population that we are anticipating coming, but we adjust based on what we currently have so that they can be included in our housing projects that we have.
Awesome. Appreciate that. Thank you. Okay, and I know we're moving along with our time, and it's been really great to be able to answer questions, some of the Q&A type questions as we're moving along and doing that in the chat. So please don't hesitate if you have any additional questions as we continue our discussion. Please add them to the chat, and some of our team will look to address those, and any other folks who are part of our panel will also do their best to see if they can grab some of those while we are still going. So let's move forward again to our next topic of staffing. And one of the challenges, of course, for rural counties is having the right staff to meet the needs for the CARE Act implementation and for the the ongoing offering of the CARE Act itself and its needs. So what have you guys, and then pose this to everybody, what have you guys done to meet the needs of the CARE Act and care populations to make sure you can provide the support for what is needed here? Because again, it sounds like we've had folks that have done some very creative work to make sure that staff have been available to meet the needs. So open it up to everybody. What are the challenges and solutions that you have found to have the right teams for the CARE Act implementation?
Well, in Tuolumne, we through the planning process, we really targeted what positions we wanted to hire, and we were able to mostly internally get that to happen. We had to be flexible because we realized that, for example, like I posted, is we put a legal aid in our budget, but then we didn't need a full-time person to do SERVs and to coordinate court appointments. So we were able to shift that to an internal analyst. But like someone else had posted, we really relied on our current QI team for data and the care court data submission process. So we already had a robust QI team. We relied on our full service partnership team to do the day-to-day case management. but I am really grateful that we had the foresight to get that clinical and forensic program specialist, that clinical psychologist, to supplement what we were already doing. And we were able to put that into place because I couldn't have run the care court program without those key personnel in place. And so that was really helpful.
Oh, fantastic.
And I'd like to add that the program forensic specialist, you know, it's an administrative role. And so we realized that although this is a treatment program focused on recovery, that we really needed a person that would buy into the CARE Act process and really understood the big picture and was administratively skilled. And we landed them. I'm not giving out the name. But I would definitely encourage to make sure you have your the person that's going to be representing you in the court system to be very, very well versed in court processes.
I would say with Glenn, a little bit different than Tuolumne, we needed to supplement our data person. So we added that position who's been very beneficial. Our QI staff couldn't have taken that on. We were able to use existing staff in modifying caseloads, realizing that we weren't going to have the influx we had thought. And so we needed to find people who were interested. So we were able to ask existing staff who had an interest. I think that's a really important piece. And then educate and do some training. My background is working with individuals myself, and so I bring some of that to the table, being able to kind of blend teaching staff, talking about program and philosophy, and then bringing some of that direct knowledge and adding supplemental trainings, et cetera. So again, somebody like Brock was saying, and Tammy, who sits in that circle, who can really speak to all of that and has knowledge of that, and staff who are willing and interested to learn and train. Sometimes you don't have people that are available, and staffing's been an issue, I think, throughout every county for the last year. So that's just a hard piece right now.
Absolutely. Absolutely. Appreciate that. All right. We're getting close to the end of our time today, but no, that's really valuable because again, just, creatively working through these challenges that the rural counties have been dealing with, and hearing your experiences is exceptionally valuable, and we appreciate that. And again, we encourage the conversation to continue even beyond this, outside of this forum, connecting with each other, sharing ideas, because again, that's what we're all here to do, is ultimately do the best we possibly can to support the CARE Act, the respondents, and the needs within our communities. So with that, I know we've got 2 minutes left. And I would like to turn it back over to Patricia just to kind of wrap things up and close us out with some next steps.
So, Lisa, hearing that great conversation between those county panelists, what are some of the things that they mentioned that you think other small and rural counties could learn from?
I appreciate the question, Patricia. And I think the things that we've been hearing quite a bit are the staffing challenges. There are many who are experiencing staffing challenges, and turnover in key staffing roles has really been problematic and challenging for several counties that I have worked with as well. And some of the solutions that they've thought about are cross-training their existing staff to avoid the need of retraining or re-educating. So making sure that all staff are being cross-trained, and making sure they're understanding the CARE Act and any of the things that would be pertinent to their role in the process. Implementing internal team meetings, making sure that folks are routinely within the department, routinely up to date on what is happening with the CARE Act. So that way everybody is in the know. If somebody needs to step in to help out, or if there's someone out on vacation or out on leave, that everybody is cross-trained and up to speed at all times on what is happening with the CARE Act. So that's something, an idea that may be helpful. Outreach and formation of partnerships between behavioral health and the courts has been an overriding theme that has come up quite a bit, making sure that there are established lines of communication between the behavioral health department and the courts is exceptionally important, and fostering those relationships and the collaboration between those teams is something that, again, is idea in action. Also providing continuous education to the public, making sure that folks in the community, as I had mentioned before, making sure that folks in the community and the stakeholders understand what the CARE Act is, understand what it means for the community and the opportunity to be able to help people who may be able to be helped by the CARE implementation, the folks with schizophrenia and schizophrenia spectrum disorders. So making sure that there are a variety of different educational tools and opportunities that can be taken to the public, taken to the communities, so everybody is in the know about CARE Act and its intentions. Also, strategies for housing. Housing is a big challenge for many counties, and making sure that there's an opportunity to collaborate wherever possible. And some of the counties that I've been working with have been in collaboration with different contractors to help renovate unused spaces in the county and maybe repurpose that space into housing, or to even build new apartment style housing that can be used by care respondents or shared with care respondents, especially if it's already existing housing that is being used for behavioral health purposes, or to address the unhoused crisis or populations in the counties. But now some of the space being repurposed to also be able to address the needs of care respondents, and making sure that any of the staff that could be staffing these housing opportunities, that they are also thinking back to the education and collaboration with the partnerships, making sure that other staff that are in these housing facilities, for instance, if staff are present, making sure that they are educated on the CARE Act and educated on the population that the CARE Act is serving. So those are some of the thoughts that I have. Patricia, is there anything else that you would like to add?
It's great. And we just, we encourage counties to share what they're hearing and share what they're learning. So, of course, feel free to reach out to us if you have any additional questions or want to be connected to additional resources, or you heard something and you want to learn more. We're happy to share that. Let's take a look at our learning objectives for today's session. Again, the goal is that by the end of this training, you will have an increased ability to apply those strategies to enhance care implementation in rural and small counties. Also, increased ability to develop approaches to expand workforce capacity, and able to identify methods to increase mental health and care literacy, and leveraging partnerships with other organizations. So there is no wrong door. So if you have questions or you want additional information, please reach out to us and we can try to connect you with the right resources. And thank you, Lisa, and thank you for your time.